Hey, we're the All People's Health Collective, fighting for care without control, housing without conditions, and dignity for each person. These are the voices leading that fight and educating you all about it. My name is Susan, and today I'm here with Vanessa Ramos. Vanessa is a senior advisor at Disability Rights California and a member of the All People's Health Collective. Vanessa's work centers on advancing disability justice and equitable drug policy through community advocacy and peer leadership. Vanessa, I hope that was an adequate introduction, but please add more if you would like. Um,
Thank you, Susan. Thank you. I always say this, but the only thing I would add is that above all, I am a mom. So I have two kids. I have Angel and Esther, and Angel has a partner now. So calling Juan into the space. And I'm also a cat mom. Meow. Uh, to little Kitty and Soul.
oh, those truly are the most important things. And yeah, I love the shout out. Thanks so much for joining us today, Vanessa. So today, the impetus for this podcast is this piece that you recently published, titled "The Ballooning Crisis: Acute Services versus Organized Care," which you can all find on the DRC Substack, and we can hopefully link that to the podcast. But the piece kind of outlines the crisis of mental health care in California, which all too often, as you know, fails to offer people like meaningful care or material support until they get to this place of acute crisis, at which point the state swoops in and locks people up through involuntary commitments, pushes people into coercive and isolating settings and locked facilities. And then when people are released from these facilities, they often don't have housing, they don't have the support they need, and it makes it all too easy for people to slip through the cracks and just continues this cycle of harm. So Vanessa, you kind of talk about this and you get much more deep into it than what I just outlined there. But I'm hoping that today we can just talk about how the system is failing people and what is actually needed to create a spectrum of mental health services that prioritizes dignity and choice and community and care, and not coercion.
Sounds good to me, Susan. Totally sounds good to me. And thank you so much for having me. I'm especially grateful to you and to all who make this podcast possible. It's one thing to get things out in written form, but it's also another thing to get things out in video and in audio form. So shout out to, my disability siblings who benefit from all that we have to share because we produce things, with all people in mind. So thank you for your time and just for featuring the story.
Yeah, of course. So I guess just to start with the title of the piece, again, it's The Ballooning Crisis: Acute Services versus Organized Care. I'm wondering if you could just share a bit more about what acute services are, what those include, as opposed to organized care, and why aren't just acute services enough?
Yeah, that's a great question, Susan. The reason behind the title uh, came to me because, or when Lex Stepping of All People's Health Collective mentioned, we were talking about like sometimes people are in an emergency, sometimes people are in a crisis, sometimes people are having a low point within their mental health. Sometimes people are having an emergency or a crisis or a low point with their substance use um, and or addiction. But why is it that the services that are developed on the mental health side are so restrictive in nature? And how is it that the substance use addiction treatment world in California doesn't operate in that same way? And And it's a ballooning crisis because the population of who we're talking about oftentimes is blurred. So much like with Care Court, the narrative begins. We're going in Care Court is out of California. It is a bill that passed that was first created or sold as, this voluntary outpatient program that was going to prioritize 7 to 12,000 people living with schizophrenia or a spectrum thereof, within the schizophrenia family. And right off the top, so many of us were profoundly against Care Court because we knew that what was being developed was more of a court system. So rather than investing money into improving access to the basic, county public mental health system, why are they investing in this in a whole court system? It's the difference between, cleaning your house or saying, fuck it, we're gonna build a whole new house, right? The cost in building a new home is way more than what cleaning or reorganizing or, knocking down a wall, could be. Um, when we think about acute services, and much of the conversation when we touch on mental health, respectfully, I want to, at some point, hope for you to invite Monica Porter Gilbert, and Samuel Jane on the podcast. And Samuel leads a lot of he's mental health policy for Disability Rights California. And he works out of the mental health practice group, while Monica is associate a director within our public policy. She's also general counsel of policy and comes to DRC with immense knowledge of federal mental health policy and has just, started off the deep end into California mental health policy, where my focus is more of the substance use and addiction treatment. And I work collaboratively with Samuel and with Monica. I'm highlighting this specifically to you because I know that you have listeners from all over the globe. And in California, we don't have a Department of Mental Health at the state level, which means that we are a very large state with 58 counties, which means that we have 58 different departments of mental health. So when a state mental health policy passes and gets turned into law, the implementation of what that looks like becomes very distorted without appropriate coordination. And we're seeing this within Care Court. The substance use lane does not have that. So in substance use, as mentioned in the Substack, the Department of Healthcare Services funds substance use addiction treatment by receiving the tax dollars, sending that off to the 58 counties. But each of those 58 counties, providers of substance use treatment, are to follow the levels of care outlined by the American Society of Addiction Medicine. So when we speak about addiction, like substance use and addiction treatment, and receiving services in acute service are high intensity interventions. So when you're using drugs, right? If I'm on drugs and I need acute services, right? I'm going to be placed at a level of care, like level of care 4, we'll say, which then that provider is holding me at that level of care until I'm ready to move down to a lower level of care. Because when you have a high intensity intervention for substance use addiction treatment, that normally means you're going to need a medical detox of sort. So if I'm on fentanyl, I may need medicated assisted treatment or withdrawal management, right? And that's something that may be best suited in a setting where I'm going to sleep at for 7 to 14 days until I moved down to that next level of care, which is normally residential. And then you get leveled down to outpatient and housing. Then you get placed on an aftercare plan, and you live the rest of your life. On the mental health side, we don't have that same matching of funding to level of care, which in my opinion is desperately needed. And again, I'll defer to my colleagues, Monica Porter Gilbert and Samuel Jane, to maybe join us on a future call, to really break that out. Or I could connect with them. And if they're comfortable with it, I don't mind coming back on and speaking to the mental health side specifically. So I'll end and just I'll end just for any feedback from you, Susan, in really pointing to acute services are high intensity interventions. On the mental health side, these are normally like locked psychiatric hospitals or emergency rooms, right? So um, people access that level of care normally when they are in California. We say 5150, which is really like a form of civil commitment of sorts, where if you are having a psychiatric emergency, you may be placed on a 72-hour hold in a locked psychiatric unit. And remember, if you have a substance use emergency, if you've overdosed, if you cannot stop using on your own, right? You have access to something called like a detox, right? And that detox is not locked. And you're only going to stay there as long as you need. And then there's a whole continuum that's already drawn out, so that you could discharge into different places. I mean, at different levels of care. On the mental health side, oftentimes because the hospital is locked, and because of that built health environment within that locked setting, people oftentimes um, are treated by like through medication, but medication is oftentimes like the main character. Uh, and the dialogue oftentimes becomes one that is medication based. So it's very customary in a locked psychiatric facility for the first thing to happen is for the client of services to be encouraged to take psychiatric medication to stabilize them. Arguments oftentimes arise on how much medication, and are you going to stay on that level of medication, right? Or do you step down a medication, and things of that sort. But I really hope that covered some of that question. And if you need more, please let me know. because I definitely have more in the tank. I just want to make sure that I don't go too fast or I don't cover too much information because it's so overwhelming, and oftentimes our system seems so broken because the general public, has no idea of, you know, the 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 brokenness within the procurement process, right? The brokenness within the insurance companies, right? Like those technicalities, and then we get into arguments about should people be held, to a 72-hour hold? Should it, like, is that appropriate? Is that not? How does this perpetuate cycles of harm? And we could get into that. But yeah, did that answer your question?
Yeah, yeah. Thank you, Vanessa. And I think it's really helpful for you to just break down some of the differences between substance use disorder treatment and mental health treatment. For me, not working in California or in this policy space, I didn't know that these were like separate tracks even. And I would imagine that a lot of people, especially those who, haven't been either directly involved or had family involved in these systems, also aren't really familiar with some of those differences. And it sounds like, from what you're saying, in substance use disorder treatment, because that's managed from more of a state level and there are more standards, there's a set of services, there's kind of a continuum of care with step up and step down services. That means that people have access to more support and like less coercive forms of treatment, whereas, when mental health services are being implemented in this really like fragmented piecemeal way, that also kind of goes hand in hand with just really like a lot of forms of coercion, especially as you described through these locked facilities, which, if you're willing to share a little more about that, even in your capacity as an investigator at DRC, I think it's really important for people to understand like what a locked facility is and how people end up getting warehoused in these facilities that are, I mean, they're locked, so functionally they are like jails.
Yeah, absolutely. Such a great question. And I know, Susan, like it's so wild to know that there's been a play on what we think of when we think of like a hospital, right? Because oftentimes when I think about a hospital, right, I go back to, you know, my grandma needing uh, support because her blood pressure went up. So the ambulance gets called, she gets taken to the ER. We're all there in the waiting room, and one of us is in with my grandma, and we're there, and the nurses and the staff are responding right to this person who has this medical condition, right? And never once are we thinking like, well, is grandma ever gonna leave, right? Or if like you've ever had a broken limb, like the thought isn't like, oh boy, like I'm gonna go in for a broken leg and then be stuck here for the rest of my life, right? Because we know that there's after care plans already, in order. Like there's an order that happens. There is no order oftentimes within these locked facilities, right? So the order that exists is one where oftentimes the staff, I don't know if you've ever been into a locked facility. I've been as a patient, and I've also been, or a client, I should say, and I've also had the opportunity to investigate, right? And to go into locked settings. And I'll tell you, Susan, that when the door locks, there's instantly this like the energy shifts. And for staff, and I've worked in locked settings, right? when you work on a unit that's locked, the feeling is different because you have a badge and the badge has like a clip off thing because, just in case somebody tries to do something to you, it's like a breakaway tag and you know that and your badge is really important because that's the only way that you're going to unlock the door, right? So when you work as a staff member, right? Like you are already put on guard, like, and so it's like there's already this built-in feeling when you drive to work, take the train to work, you arrive at your work location, you go in, right? And then like that once you go in, right, there's all these levels of security just in case. So that for me, when I worked as staff, would put me on edge. So that automatically would have me looking at clients through a bias of, well, shit could go down. You know what I mean? This motherfucker's wild, right? And when I was a client, when I was a patient, one of the things that happened is when people are looking at me like I'm weird, I act even more weird than I naturally do. You know what I mean? So when you're in close quarters and people are just watching you, and every time you get out of a room, there's like you're in observation, that does something. At least it did it for me. And it normally didn't bring out the best in me. It normally didn't bring out the like, we do recover, right? Or I'm going through a hard time. Others go through a hard time. This is just what my hard time is. And I'm going to get through this. And there's people working here that are like me. And we are sharing they're sharing stories with me of recovery that make me know that, you know what, I too one day can get better. And I too one day maybe can even go back to work there. A lot of that is lost. And that's what I mean by some of the built health stuff. And I'm currently working with Monica Porter Gilbert and others on really highlighting what is that built health environment within a mental health unit. So I will reserve some of that until, we move further along collaboratively. But I'll tell you that my experience in working in substance use treatment and being a client of substance use treatment, I the experience is completely different. Where there's annoying rules. You can't wear that. It's time to get up. Don't go back to your room. You have to help clean up, and it's just all that you're just like, leave me alone. Um, and but the people that work within the rehab units that are unlocked are people that oftentimes that are in recovery or they have increased their ability and their understanding of what healthy use may be for them, right? So I have friends that are totally abstinent and we go to 12-step groups. And I have other friends that fell into addiction, went to treatment, are no longer physically addicted or mentally addicted to the substance, but don't want to live the 12-step lifestyle or the total abstinence lifestyle. And maybe they still drink every now and again. Um, so whether someone's in recovery or they've learned, what to use and what not to use, or how to use, they're working there and they're sharing their stories. And the clients, right, are taken outside to outside 12-step groups, are taken outside to functions, and people from the outside that are in recovery or in remission, we'll say, or whatever we're going to call it, come back into the rehab and they tell their story. And many people transition out of a residential rehab, but they come back. They have access to coming back. And I like highlighting, Cry Help, which has several locations in the greater in Los Angeles County, which is huge. But at Cry Help, many people go through the treatment program, but they go back to hang out for meals, or like they just go back and hang out with the clients, or in between their job and school, and hell, I do that, they come back, they pick up clients there to take them out, right, on family day, which is, I believe, Saturday or Sunday, right? Like, you could go bring food, music's playing, right? There's like outdoor, indoor, there's groups, like during the week when you're in rehab, you're going to get up at this time, you're going to be in your morning group at this time, you're going to be, right? So there's a lot of structure, but the services are there and those doors aren't locked. And people are so busy and so preoccupied with receiving the services that they need, right? That they're not like, no one's tripping on the locked door. And if someone's like, I'm leaving, oftentimes staff comes and goes, are you sure? I don't know. You may not be right. Like, what's bringing this up, right? But there's a form of clinical support. There's a lot of multidisciplinary team stuff going on. You may work with a therapist. You may have your counselor. You may have your registered alcohol drug technician. There's people there that you're working with. You also have your other peers, since people are dormed together, and that's done on purpose, right? In share rooms, there's a camaraderie, right? That's built. So when one wants to leave, the other encourages to stay. So there's a lot of this going on in locked residential facilities, Susan. Unfortunately, that's not what we see, right? The focus is primarily make sure the door's locked, make sure the staff badge is has a break off in case, somebody goes wild, and there aren't people from the outside coming in to hang out. When have you ever heard of like, oh, I'm going to go hang out at the local psych hospital? That doesn't happen, right? But it does on the substance use side. Those things are very important. Oftentimes in locked facilities, staffing is really hard. So it's really hard to keep people in those jobs because it's so intense, right? Like, it's like a hard job to have. It's like being a correctional officer at a prison. Like, I mean, it's just like that's a hard job to have. Um, so there's a lot of turnover, right? So when there's a lot of turnover, some of the scheduled groups that exist within locked facilities aren't happening. So I've gone to places, and my colleague Paula Sandoval, who would be great for you to have on your podcast, Susan, Paula, can talk to you about what happens at College Hospital Cerritos, right? She in the investigations unit, led an incredible report and monitoring and investigation of people who went into College Hospital Cerritos for mental health reasons, who live with intellectual and developmental disabilities, such as autism, and other types of intellectual and developmental disabilities. And Susan, when we've gone in to invest to monitor, the on the wall it would say like 10 a.m. this group, 11 a.m. this group, 1 p.m. this group, 2 p.m. this group. But you go and those groups aren't happening. And when you start to ask why, it's normally those groups happen if there's enough staff, right? So when most of the attention is placed on the doc and on the lock and security, it changes the environment within the setting. People oftentimes don't always want to work in those settings long term, and people receiving services don't always receive the services that one imagines that they're receiving because there's nobody to run those groups, right? So, in many locked facilities, there are um, there are uh, um, there are times, and it's where the separation from natural supports happens because to build it up a locked facility is like a big thing to do. And oftentimes people are placed not in the county in which they live. So family members and friends have to travel long distances. And because of the restrictive nature, the visits are like super monitored, right? There's a lot of like, oh, you're at this place, and people are looking at you like, yeah, but when you visit someone in rehab, there's more of like, there's food, there's energy. So I'm not sure if this is making sense, but it's like there's the built health environment plays into the results and the energy that is felt, not to mention that people that are oftentimes in locked mental health facilities, right? May be under conservatorship orders, or there's legal reasons why they just can't be released. And that type of pressure on a family, on a hospital, and on the person um, leads to a lot of stress, which the person in that environment can feel, right? So if you're the client, you know that you want to be released to that next level of care, but that next level of care, Susan, doesn't exist because we haven't invested in step downs. So that person may start to become frustrated. And in a locked psychiatric facility, if you start to display aggression, or you will be restrained and secluded. And every time you're restrained and secluded, that goes into your chart. So that limits the placements, right? That limits the placements. It's as if you, when you were in detox, if you um are showing signs of aggravation or of violence or things of that sort, you may not be there may be a limited amount of residential drug treatments that may want to take you or may want to provide you services because it looks a certain way on paper. But this is important to mention, Susan, because currently in residential substance use treatment, there is no restraint or seclusion. People are not being restrained and secluded. And I believe that a lot of that has to do with the lock on the door and the built health environment where people just aren't as prone to that. Where on the mental health side, what I see is that when so much is invested in the lock on the door, and the safety, and is this person taking the medication, then we by default sometimes overly medicate or overly sedate people. So people are in a very are operating in a medicated, in an overly medicated way, right? But the hospital wants that to keep everyone at bay, but that does not prepare the person to reintegrate into community. So I go back to ballooning crisis, because rather than building up more locked facilities, why don't we invest in building step downs? Because what's happening is people are going into locked settings, but they're not being released they're not being reintegrated appropriately. because there's no step down. So they're being released back into community or back to live with their family members and just do an outpatient program. But that's not necessarily what people need. Sometimes people may need, a residential step down that provides them housing and clinical supports and social supports, right? And, preparation for employment and things of that sort. But that's not built out in the mental health side, which is why I highlighted the very powerful piece by the family members, Teresa and Lauren, in Housing That Heals, where they point to the need for a full continuum on the mental health side for people that are leaving these locked places. And I can't uplift their stories enough because they invested their resources, into this. And I caution and beg the audience to please start to build partnerships with family members, because sometimes there's this nasty split between the client movement and the family movement. And have been guilty of it where I've gone way hard on the family members, but it's been family members like Lynn Gibbs and like Teresa and Lauren and leaders like Karis Myrick who have really encouraged dialogue and connection and who remind us that we're in this together, and I just want to say that because I believe that collectively we could come to a place where when we don't agree with a solution that someone else is coming up with, that we find ways to sit down and to talk it out, to debate it out, to have those hard conversations, because there are these bottlenecks. So I'm not sure if that was too much information, Susan.
Not at all. No, that was all really, really rich. Thanks for sharing that, Vanessa. Yeah, what kind of sticks out to me is just what you're saying about like in locked facilities, there's already this atmosphere of paranoia and looking at clients with a bias. Kind of what I'm thinking about is this like fundamentally pathological view that we have of mental health, that says, especially for conditions like schizophrenia or conditions that are associated with psychosis, um, they're thought of as like largely or maybe entirely genetic, as something that's just like essential, like innate to a person, even though these are also things that are like really heavily racialized, that are structural, that are, like if I don't have housing, if I don't have food, if I don't have family and community near me, like yeah, I'd be struggling a lot too. I probably would not be very much in consensus reality either. But there's this way where it's like the way that we think about people with mental health crises is so othering and so demonizing. Um, Whereas maybe there's like with drug use, I think more people maybe understand that this is something that can happen to anyone or has happened to a lot of people's family members, members of community. And so there's more of a sense of like a social world around that. And, these are people who are close to us, who, are members of, um, yeah, our world. Um, yeah, I'm just really chewing on that right now. To me, I'd
And we're
almost feel like there's,
cool. And they're
yeah.
cool. Just shout out to Kurt Cobain, shout out to Prince, shout out to Amy Winehouse. There's so many really great people that have given us and have left us with so much to enjoy in the form of art and music. Shout out to Rich Homie Quan. I didn't realize that he died on accidental overdose. I mean, there's just so many people that have done really cool things while on drugs. And I think sometimes we forget, greats like Vincent van Gogh, right, who developed some of his most beautiful pieces while in a mental health crisis, in a psych facility, or the wonderful Yayoi Kusama, who is a beautiful Asian woman who lives in Japan and produces art that fills up our world, and she lives in a psych facility, and she has multi-million dollar contracts with Louis Vuitton, and she's featured in the San Francisco airport, and you could catch her across museums in the US and all over the world. And I say that because sometimes we forget that some of the most beautiful creations that so many of us appreciate are when people are not at their best, right? But there are freedom fighters who have decided that they're just going to create and just do things the way they do them. And by the grace of God, they get to receive, or they have received, the services maybe that they've needed. And now our call is to elevate those types of interventions, right? The like, may there be music rooms in all settings where there's people with addiction, or mental health, receiving mental health treatment, right? May there be art rooms, may there be color and poetry, right? May all the different parts of us be amplified and highlighted. Because when I'm in crisis, Susan, when I'm in crisis, that's just one part of me. I'm still a mom. I'm still a mom that can't wait for these symptoms to pass, so that I can get back to my family. And when I was on drugs, Susan, I was still a mom. I needed to get the services, and may people uh advocate, right, for the types of services that we want to see funded, so that money doesn't go into building court systems, right? But money goes into building the solutions that Teresa and Lauren highlighted, right? That services that Karis Myrick has long advocated for, right? Pure respites, the Terra houses, right? May those be funded as well, because we have a ballooning crisis, and we have this obsession to put people in the most restrictive settings. And there's been greats like Lois Carter, who, because of Lois, um, there are federal laws that 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 are supposed to prevent people from being in the highest restrictive setting. There's federal laws pointing to keeping people in the least restrictive settings, but the common person, the general public, thinks that we have these safeguards in place that prevent this, but we don't, Susan. People are still being held in the highest, most restrictive level of care. And when they're not, they're released into being unhoused, like no housing, no residential treatment, none of that. So when we see them suffering on the streets or tormenting society or whatever we want to say, right? Because a lot of my friends have been punched by someone on the street, or I don't want to ignore the fact that there is death and destruction happening, and some people are not having a good time, and some people are languishing in plain sight, but how do we build up solutions so that those in lock settings ready for the next level of care get moved down, so that those needing more acute services get those services, right? So I'm sorry to go on that rant, but I don't know why I started, girl, honey. I started channeling Amy Winehouse. I started channeling fucking Prince, girl.
No, tap into the pop culture. And I think that's a really important point that, yeah, I feel like a lot of people need to make certain mental health conditions and like something so essential and something so other because the thought of something like that happening to you or someone you love is so terrifying, and people like can't hold the idea that this is something that can happen to you. Like you can't hold your own vulnerability. But the reality is that like the distinction between, wellness and illness is really like fragile. I mean, anyone can slip over at any moment. And like you're saying, and we're all people, like we need so many things that aren't just medication. We need relationships, we need meaningful creative pursuits and community, family, purpose, and of course we need housing and food security and money. Like we need all of these things to be well. Um, yeah, so I think I really appreciate you for just like pointing out all of that
Yeah, and
and shouting at Amy.
there's greats, honey, like Leah Harris. What, honey? Yeah, like Leah Harris, who oftentimes, talks about you know, a crisis support that isn't, in restricted settings. Or we have great researchers like Nev Jones, who's really looking into assisted outpatient, right? And what are those? Why are people feeling out of that? What's the holdup? Nev also has done a lot of work on peer support, right? What is that? What is peer support, right? Like there's just a lot that she's done, and I can't help but to mention Jesse Mangan of, and I have speech stuff, so sorry if I just be messing up everyone's name and stuff. And but Jesse's got the Committable podcast, that features, so many stories, and he posts such great information on the Protection and Advocacy Network as a system, right? And talks to different protection and advocacy agencies. So, Disability Rights California is a protection and advocacy agency. So, every state within the US Republic and territories is federally mandated to have um, a protection and advocacy agency. And the reason why is because back in the day in New York, Susan, in your town, right, we had Willowbrook State Hospital, where people were languishing in the hospitals. People were chained to beds. I mean, these conditions were grim. And when Geraldo Rivera broke that story, right, because the staff at Willowbrook said we can't work under these environments, and they left. So I call upon the whistleblowers within the if you're working at a place that is doing bad things, please give us a call. You can reach me, and I'll connect you with folks, or let I uh, please report it. We all need jobs, and I'm not telling you to walk off your job, but at least report it, because sometimes the people working in these settings are one of the only people that can actually make change. And that's what happened at Willowbrook Hospital. Two people that were working there left, and one of them had the key, and they knew Geraldo Rivera. So Geraldo was rolling the tapes, opened up the facility, and started broadcasting live news. Hey, look, this is what's happening. And when people saw that, they were like, what? And you know what? That has not gone away. The people at College Hospital Cerritos breaks my heart. Shout out to Robert Reyes Villa Gomez, who is working so closely, and Ida Yinka Glover, who works at Disability Rights California, our whole investigations team, managing attorney Liz Lodgson, and the wonderful Richard Diaz, like I mentioned Paula earlier. I mean, these are folks that are going into places. And Susan and listeners or whatever, of the podcast, dude, we met with people that are being held 8 years after being ready for discharge. Imagine being held in this tiny little like place where you can't have pictures up on the wall. Like you're held in a place that you're only supposed to be there for like 72 hours a month, maybe, how would you act? How would you behave? How would you behave if you were held in a place 8 years after you're ready for discharge, 6 years after you're ready for discharge? Would you not act out? Would you not misbehave? And you know what? These people, these beautiful people, are sometimes held in restraint for 6 hours at a time, for 3 hours at a time. So I understand that some of my people, I know we act out sometimes. And this is not even a conversation on should they be restrained and secluded or chemically restrained or, 5 point restraint and all that. Dude, even if you think that's appropriate, you mean to tell me you think people should be held to be chemically restrained, to knock out, to be tied to a bed for 6 hours? I don't think you think that's appropriate to wake up and not be able to move. I don't think you think that that is help. So even to the physicians and to psychiatrists, right? Please help us, point to solutions that are humane, and that's all we ask. But Susan, I know that, we can go on, and I think you're just the coolest. It's such an honor to be interviewed by you. Next time, if you have me again on the show, I promise to wear cool earrings, but can't promise that they'll be cooler than yours.
Thank you so much, Vanessa. It's been such an honor talking to you, and I learn so much every time we're on a call together. Yeah, even just from this call, there's so much more to talk about. There's so much more from the Substack article to talk about. So I'd love to have you back for a part two, part three, etc.
Thank you, Susan. And if your listeners have ideas for Sam Mickens of Disability Rights California. I know that Sam's always open to taking stories, and to posting them op-ed style, just a shout out uh, to our comms director who I harassed over posting that Substack. Boy, I was every day, come on, Sam. So, Sam, if you're listening, I love you, brother. I hope this makes up for it.
Thank you so much, Vanessa. Is there anything else that you just want to share on the podcast before we log off for today?
No, I love you to you,
Me too.
Susan, and Pachaco loves you guys, and God wins, honey. Bye.